Plan for today, we will talk about just a quick review from last week. We'll cover abdomen and pelvis, and then we'll end class a little bit with the stones coming into the valves. Portfolios are due today. At midnight. And then next week is our last class, and then there's 2 weeks off. Next
You don't have to get up at 8 a.m.
next week. No, you can if you like, but there's a class.
Why?
I'm not here.
Why do you have the 2 weeks off? Is it because of the second week's because of Easter, right?
Yeah.
What's the week before?
I'm going to a course up in Edmonton.
Okay.
And it's like Wednesday to Sunday.
Okay.
So next week we'll do head, face, neck. Next week is cancel class because of the course. The week after is actually the holidays on Monday. But Mark and Meryl have said that if one class is canceled, we'll just cancel all 3 rather than have everybody come all to the 1 or 2. So after that, there's 2 more weeks. So those last 2 weeks are strictly just review for everything we did over the semester. Okay, so anything medical, anything trauma, we will cover those last 2 weeks. Next week, if you can, go over another mock scenario again with your supervisors so that your expectations are clear. I think with STS, it might be a little bit challenging because there may not be too many events left. Some supervisors before have come in and actually borrowed the classroom for an afternoon and then just went through mock scenarios with a bunch of people. So it might not be a bad idea to contact 1 or 2 of the supervisors or all of them to see who's willing to do that for you. But try to get 1 scenario in next week if you're kind of bored at your placement site. I think most sports are done right now, and so I think technically you only got clinical. If clinical is a little bit slow, maybe go through some mock scenarios in the clinic. And then last but not least, just the deadlines, the due dates for the 2 assignments that are due at the end of the semester. The brochure from the material that you made for Janelle. So you guys are making a poster right now. So just convert that into a smaller version that you can hand out at doctor's clinics and stuff like that.
That's just for the 1 person selected?
Yeah, yeah. And everyone should know what topic that is, right? If you don't, just let me know.
If we narrow it down in first, do we narrow it down to that? Like, I did osteoarthritis on acupuncture. I don't do that for
Versus,
this osteoarthritis.
it's up to you.
Oh.
It's completely up to you. So there's a lot of flexibility in what we talk about. Somebody asked about doing, because I think they wrote their paper on a case study. So I had said, well, just provide general information about whatever topic, and then use the case study in the brochure as an example. Okay. If you have specific questions about the assignment, then let me know. Okay. And then the video, again, the podcast guy from Optimal Therapies, he kind of bailed. So there's 2 other options if you're still not comfortable making stuff, like making media. There's the Start Lab downstairs. Do you guys know where the Tim Hortons is? Just right across the hall. There's that long hallway. It's the T-wing. It's just right in there. There's a media area where they can actually help you put together and edit videos and stuff like that. And there's also the Start Lab, which is anything that has to do with computers. It's free for students. It's actually student run. Okay. Again, the reason why we want you to start making these things is because, I'm sure a lot of the guest speakers that have come in and talked to you guys already, they own clinics. A handful of them are graduates from here. A couple of them I actually taught, and that was just 4 years ago. But nowadays, they're starting to put together stuff like this for their business. If they own a clinic, most chances are they're probably going to be making some of this stuff for their clinic to help promote their business. In other situations, kind of like at Optimal Therapies, the practitioners, although it's not our business, they tell us that we should try to make some of this stuff for the clinic as well. So part of my contract with Optimal Therapies is 1 hour a month we have to do stuff like this. We don't treat patients, we have to try to contribute to the clinic and advertising and marketing by putting stuff like that together. And it's pretty cool to have these skills, not just for AT, but for anything else that you want to do. Do you guys have questions about today, next week? Oh, it's just an evaluator.
Oh.
So excited. Sorry. I thought you guys had so many guest speakers this year. Sorry.
I thought there were some cool injuries. Someone would come in and be like, oh, this arm was equally shot.
Actually, that's not a bad idea for next week. We did have Courtney and Reed come in and talk about their CPR experience, so I thought that was pretty cool. But if you guys have any friends or know of anyone that could come in and talk about some cool experiences, whether they be a therapist or on the receiving end if they were like a patient, just let me know. So cool. So you guys have seen this before. Put this up every week. And last week we added in Canadian Cspine Rules. This is out of the Alberta Health Services document. It's that 300-page or so document that I posted. I just took a screenshot of the page that actually has the algorithm for managing C-spines. Okay. So if you want to take a look at this, it's here. I posted the entire document, the 300-pager, on Blackboard. What I might do is just put this up as well by itself, so you don't have to download all 300 pages. So if you want to take a look at that during break time, you can. Where that fits in is here. Okay. Well, actually here and here, because part of the C-spine rules talks about what type of situation it is. Is it a motor vehicle? Is it a fall from a height? And that's one piece of determining whether it's a C-spine injury. Again, that's usually where the paramedics stop. As soon as it's a motor vehicle accident, they put them on a board and they send them. But now what they're trying to do, again, like we talked about last week, is they're trying to have paramedics do a little bit more to determine which ones are actually false positives. Okay, which ones, we don't really have to send to the hospital. And in order to do that, they would want paramedics to do a little bit more, such as active range of motion. So like the final step in the C-spine rules is just have the patient rotate from side to side, so 45 degrees. If the patient can do that, then you just put them in the car and tell them to go to urgent care, but you don't necessarily have to put them on a board. Okay. That piece, paramedics never learn in class in their courses because they're strictly pre-hospital. Now we do because we learn that in Janelle's class. Okay. So that's where the C-spine rules fits in. From talking about that last week, did any questions come up over the week regarding the C-spine rules and like how you would use that at your practicum sites? Okay. A couple examples, like last year, like I don't know what happened this year with STS at Ruston, but we've had a couple spinals walk up to us. What's the word? They fulfilled the first part of the criteria, so it was a fall on the head or something like that. And then the second part was midline pain, and so sometimes they didn't have midline pain, but they're really, really stiff. But the third part was we would try to get them to do range of motion, and they wouldn't want to. So we would just tell them just stand there, and then someone would automatically grab C-spine, and then we put them on a board. We did standing spinal. So we had a couple of those last year, but that was an example of how we actually took it a few steps further in applying the C-spine rules for that particular scenario. The paramedics probably would have just put them on a board right away. Okay. So anyways, any questions about stuff last week or the C-spine rules? Again, last week we covered thorax, so if anything comes up about the thorax injuries that we managed. Last week we did flail chest scenario, and what was the other one?
We just did a practice one before that.
Oh, okay.
Just not being conscious the whole time.
Yeah.
Okay, just process. Okay, so this week we'll do abdomen pelvis. We'll start off with abdomen first. There's not too much to talk about the abdomen because most of it is internal. It's just recognizing. There's only a couple where we can actually do something as a therapist. We can actually perform some type of management on site. So for those, have you guys downloaded this? Again, it's online. So we'll just go down the list. A lot of this I think is probably repetition from what you've learned in EMR or might have talked about in Janelle's class, like with referred pain. So the first part, well, the first condition is a lumbar spine fracture dislocation. So spinal but in the lumbar spine. Generally speaking, treated the same as if it were a C-spine injury or even a T-spine injury. In this particular case, again, more importantly, don't move the legs. Okay. So any questions about L-spine injuries? Okay.
How would you put them on a spine?
Log roll or lift and slide.
Okay.
The better way is the lift and slide. You guys have log rolled multiple times already, and the piece of the body that tends to move quite a bit is usually between the torso and the legs. Okay, so therefore the lift and slide would probably be better. But again, at the end of the day, ultimately which one is better is the one that you practice and your team has practiced the most. The second one was evisceration. Now, evisceration and the stitch I think those are probably the two that we have where we can actually do something on site. So evisceration, you guys talked about this in EMR, right? Where the organs are showing. Okay, so what do you do for that? Okay, so that's layer number 1. What's layer number 2? Tinfoil. Or something that's non-exclusive. So plastic will work fine as well. Tinfoil is good because you want to keep it heated. And so what's that last layer? Blanket. So inclusive dressing is the second one, and blanket is the third. Okay, so the first one keeps everything moist. The second one, it doesn't allow blood to soak through into the warm blanket. And it tries to keep some of the heat in and moisture in, and then the blanket on top is just to keep everything warm. Okay, so it's just 3 layers. You ever put anything back in? No. When it comes to the liver, spleen, kidney, appendix, and all these other things, all the way down to the stomach, it's just recognizing the 2, I'd probably say the 3 that are most common: liver, spleen, and kidney. Okay, the one thing you need to recognize between those 3 is just where it hurts. So when you palpate the quadrants, which quadrant is going to be sore? So liver would be upper right or upper left? Mainly upper right, but the liver does go into the left a little bit. It is possible that you have pain with the liver on the left as well, but it'll be along the ribs. Okay. Where does it refer? Right shoulder. Sometimes it says the left anterior chest and substernal. What does that sound like as well? Sounds like a heart attack. So now it's your job to try to differentiate between the 2. Okay, that's where the referred pain is. With a heart attack, what will you not see? We just talked about it 2 seconds ago. On palpation. Okay. So with a heart attack, you're not going to get a pin on palpation. Okay. We're going to skip spleen for a second because that involves a little bit more discussion. Kidney is usually the low back. This is mostly posterior. So that's the biggest difference. Okay, usually like along the ribs again, but in the back. One key thing to look for that you won't see with some of these other conditions is blood in the urine, also known as hematuria. How do you know it's fresh blood? Right. What's old blood look like? Black or dark, so like iced tea. I know you look at iced tea differently. What? Hematuria. Sorry.
You're still talking about the bowl.
Oh, sorry, I didn't mean to go. Okay, so that's trauma-related. Realize there's potentially kidney stones. What's the difference between the trauma-related one and kidney stones? Mechanism. There is no trauma with kidney stones. It might look like they got hit by a sniper, though. I was working in grad school, and one of the undergrads was walking, and he just collapsed on the ground, and he was in the fetal position, and he couldn't move. He was in so much pain, and he couldn't move. We had to call EMS because we couldn't get him up. And he was like that for about half an hour.
And his kidney stones?
It was terrible. Like it made me feel nauseous, the amount of pain this guy was in. So, do we have to worry about it? I'd probably say generally no, but just realize that if they have a lot of pain in their low back and they hit the ground and they're in the fetal position, that's a pretty good, well, you have to call it this because they can't ambulate. And there's something significantly wrong. So that, what we can do for that, probably nothing. Okay, they just have to try to pass it. Or worst case scenario, they'll go into surgery. Appendix, this is, which quadrant again? Lower right. What's the spot called? Bernie's. 2 landmarks. What's one? Kobe.
Belly button?
Belly button. And what's the other one? ASIS. Good. And where is McBurney's relative to which end? 1/3 in. It's really specific. That's McBurney's point, lower left, lower right quadrant. Not much we can do that except for call EMS. In Arnhem, it says it typically happens between 15 and 25-year-olds. Okay. The one thing that you might see with appendicitis compared to the other ones, maybe spleen, is the fact that if it's infected, if it gets really engorged and infected, the person might have a fever. Okay, so then that's when the sample comes in. Okay, so if they've been sick over a week or so and there's pain down there, it's really painful, then you might want to refer them right away. What can make that thing rupture? Contact is one. What else? So there's a swollen piece of, well, the end of the intestines that's swollen in here. Besides trauma, how else can that rupture? Valsalva. So if you increase pressure in here, so if they try to do a squat, and they also say sudden rotary rotational movements might make it rupture as well. Okay. So if someone's trying to push through, but they've had a fever, they're really point tender down there, you might want to tell them, let's just take care of it first rather than continue to, like, because some kids might want to push through pain like that. Okay? Any questions so far? Okay, spleen. Curside, that is pain into which shoulder? So left side, again, that might mimic heart attack. So the way you differentiate is palpable. Another way to differentiate is because it is related to mono. What's mono again? I just see your lips. Sorry.
Then you just like feel like you're sleeping all that.
Yeah, so you're sick, but it's when the spleen gets, is it a virus that infects the spleen? And then it gets bigger, it enlarges, and now it becomes prone to being ruptured. Again, sample. Okay, so that's where you find out that information. If they have pain in the lower left, if there was trauma potentially, and you've interviewed them, one question in there might be, have you ever been diagnosed with mono, or have you been sick for an extended period when you were younger?
What does this thing actually do? Like, I know people that have gotten their is there any function?
What do you guys think?
Filters.
Filters blood. Well, the liver does that as well.
Breaks down blood cells too.
Breaks down blood cells, stores blood cells. It's one of the lymphatic organs as well. Okay, but all in all, it houses a lot of blood. So when it ruptures, there is extensive bleeding, and you can see someone go into shock right away and pass out, usually in less than a minute when it ruptures. What is that? Oh, it's a boomerang.
No, that's not what most people think.
How come it didn't come back? Wow. No wonder my bananas get bruised. I'll get one of those. Okay, so last year, it was a football camp in May, so it's coming up. And what had happened was a kid fell on a ball somewhere in the abdomen. Wasn't really too sure exactly where they fell, but they got hit in the abdomen because they fell on the ball. Complained of a little bit of pain, and there was two therapists, student therapists that were certified, and they went to take a look at the kid. He just kept complaining about going to the bathroom, it really hurt him here. His abs wouldn't stop flexing, like those types of things. But the person was, red, pink, and dry, and very coherent, knew everything was going around and all that. And so after talking to the kid, because they were like fully alert and walking around just a little, pain, they were like, well, it's lunchtime now, so why don't you, just go to the calf, grab some food, and when you get back, we'll check you out again. And the idea was maybe 5 minutes and then come back and we'll take a look at you again. On the way to the calf, the kid collapsed. Some kids had to come call the therapist. The therapist came running and the kid was already pale with green lips. I don't even think it was a minute. He just, so then when that happened, they called EMS and they got him in, blah, blah, blah. But anyways, the interesting part of that was during the interview. So never had mono, just fell, that was the mechanism. But the one thing that was cool about this story is that the student athletic therapist had a feeling about something. wasn't sure. The kid kept saying he needed to go to the bathroom, wasn't sure exactly why. The kid hadn't eaten breakfast, so, but the certified was like, well, everything's presenting okay. They did take a first set of vitals, which were normal. And then after going through all that, the kid had to have his spleen removed. After going through all that, the student decided to do a little bit of research on their own, because like obviously that shakes you up a little bit. So she did some research and she found out that one of the symptoms of ruptured spleen is the feeling of needing to go to the bathroom, or needing to fart, can't fart, like that kind of thing. I don't know what the type of flatulence. A flatulence is a noun though. What's the verb? Flatulate. Okay. I just made that up. Flatulate. I flatulate. Okay, so the kid felt like he needed to do that, but in all the articles and all the books that we've always used, it never said that. And that was the one key thing that was weird, and that's why she had a gut feeling. She was afraid to tell the supervisor.
Was he just felt like he had to go back, or
But he couldn't, yeah.
he couldn't?
So what did the certified do wrong?
It was almost like, should we call you miss or should we not call you miss? In that sense.
Yeah, but if he's coherent, like what did they miss then that should have cued them? Like aside from.
So personally, I don't think anyone did anything wrong.
Oh, okay.
I don't think anyone did wrong. But if you put yourself in the shoes of a certified person, you know, she felt a little bit guilty that she missed it, right? If you're in the shoes of the student, she said she felt bad because she didn't feel like she could say anything to the certified because she didn't want to cross that line. But there was something inside of her telling her something weird was going on, but she was afraid to say it. So if I was you, I would say it. But there's a way you say it, right? But you should always speak up if you feel like something is wrong, especially like I think that's a perfect example. So in that particular case, there was no curse sign. In most resources, it says it doesn't really, they don't really feel it until later on. But one of the things that the patient reported immediately was that feeling to flatulate. Okay. So anyways, if you suspect, so you take a history, there's like some key signs, the trauma, the mechanism, they've had mono before, lower left quadrant pain, minus curse sign, I would just refer right away, call EMS and get them going. Okay, because it does bleed relatively fast. It's a big organ. Any questions about spleen injuries? Okay. The next one is bladder, ureter, urethra. They do mention in Arnheim's book something called runner's bladder. That's when you run with a full bladder. If you have a hollow organ, such as a bladder or stomach or any of those things, they're typically not problematic when you play sports. It's just when they're full. Because when they're full, now they're technically a solid organ. And if they're a solid organ, they can rupture. So if you've got a lot of urine in your bladder, if you get hit and it ruptures, then you have some issues. Because all that urine is going to be inside your abdominal cavity. You need an infection, blah, blah, blah. Runner's bladder is when you have a full bladder and it bruises, and then you have blood in the urine as a result of that bruising.
How do they deal with it if your bladder ruptures and you get urine in your
And you're what?
You get like urine in your abdominal cavity.
It's surgery. They put a lot of antibiotics and try to clean it out as best they can.
I have one other question, sorry. With the spleen, if it ruptures, would it be like super hard to palpate? Like it would obviously be tender, but
Yes. So if you go all the way down to the last row, generally speaking, I put down other, but those are all the signs and symptoms of all the abdominal injuries. So you'll see shock symptoms, but anytime there's an organ injury, the body will automatically try to split it, so you'll feel rigidity. Any questions about bladder, ureter, urethra? If there's any damage to those, you'll get blood in the urine as well. And again, location. That's how you differentiate. Hernia, the one thing you need to be aware of is, so hernias happen, like a lot of times they're not really problematic. They become problematic if the organs in the abdominal cavity poke through and they get pinched. Okay, so in some situations, if it's a really bad hernia, you'll get the intestines poking through. And then if the hernia strangulates those intestines, then you have intestinal blockage. Okay? And if you're blocking your intestines, that becomes a problem because you can't digest. A lot of times it's just surgically repaired. It's a very simple surgery. For our purposes, what we try to do is just try to assess it and then refer. To pick it up, you just have to put your hands on top of the area where it looks like there's a hernia and have them do a Valsalva. Okay, and if it pops up, then refer. The last one we'll talk about is a stitch. Okay, I guess the generic term is called a stitch. Nobody really knows exactly what it is, if it's a muscle spasm or it's something else. Most people think it's a muscle spasm, diaphragm, or abdominals, or one of the oblique muscles, one of the abdominal muscles. But in most resources, they say it's idiopathic. They're not sure exactly where it comes from. And if you don't know what causes the injury, then it's very difficult to treat it. But what they've seen is there's some home remedies that tend to work. What have you heard? Yeah. Stitch in the side. Okay, so that was one. So stretch. So because of that, they think it's muscular. Okay, so the one is stretch the side that it's cranking on just by putting your arm up. Side bending opposite way.
Focus on like really exhaling.
Exhaling.
Like breathing, but like when you exhale, like get rid of all of your air.
Okay. In Arnhem, they talk about two different things that deal with exhaling. So they do think it has something to do with the diaphragm, actually. And because two of the other recommendations deal with exhaling. And like I'll show you what those are in a second. Has anybody heard of anything else?
Breathing through the nose.
Okay, so same idea. So it might be respiratory, might be diaphragm issue. So inhaling, exhaling.
Well, I heard that if you eat 2 hours before, then you're more susceptible.
Okay. I'm not sure why, but I've heard that as well.
The way I was explained is because there's not as much blood.
Okay.
More of it's in the stomach.
So then the muscles don't have blood, they cramp up. Okay, so like it seems to me that it still goes back to the muscle. Any other?
I don't know if you said it, but I was always thinking of my hands on my head when I was running.
Okay.
If I had a stitch and regulate my breathing, so I try and breathe in as much as I breathe out.
With your hands over your head.
Yeah.
Okay. So I think that sounds like Jeff with the stretching with the hands above the head possibly. Well, but Jeff said just one side. So the one in Arnhem is the stretch. So I think those two are the same. The other one, it says flex and flex. So they suggest you fold over your hips, and so it's like you're stretching. So just fold over, and then flex your abs. It's supposed to be some type of release, so it's a muscular thing that they're talking about. And then the third one is called step and exhale. Somebody brought this up yesterday. I can't remember where they got the information from, but they say that whenever you step, so step with the foot that's opposite of where the stitch is, apparently. So you step, and then you exhale, and it's supposed to release the one on so if you step with your left, it's going to help with the stitch on the right, and vice versa. Okay. So that's what Arnhem describes. Those are 3 different ways. I usually go trial and error. If an athlete has one that's really, really sore, the first thing I think is hydrate. The second thing I do is I ask them when they've eaten last. And then minus those 2, if there's no other medical issues that's involved, so I do a sample, then I just have to try some of those and see which one works the best. And then I tell them if it happens again, then just to repeat whatever movement they did to help release it. Like the problem with managing a stitch is that nobody really knows exactly what causes it. So any questions about abdominal injuries?
Is that kind of similar to like when your calf cramp too? Is that,
Same idea.
or is that just all muscular? Or is it the same idea? We don't know what exactly that is.
Yeah, there's many contributing factors. To put your finger on exactly one of them, you can. And so there's ideas. So lack of blood, lack of oxygen, probably causes the cramp, or dehydration causes the cramp. So, I mean, whether or not drinking more water helps, I really don't know.
Do you have tricks for the calf as well?
I eat proprioceptive stuff. So if it's a calf cramp, I just tell them to pull their own toe towards them, and I usually get out. Sometimes I do it to good release. But yeah, they're kind of annoying because again, it's hard to tell. It's hard to treat it if you don't know what the cause is. So if you know exactly what the cause is, it should be pretty easy, right? But a lot of times, again, for me, it's trial and error. So, any other questions about abdominal injuries?
Did you talk about this
Oh, sure. No, I do not. Dyspepsia. So indigestion. The one thing that happens to everybody, so Tums with the antacids. The one thing I just wanted to mention with dyspepsia or heartburn, for example, is that mimics another condition. In fact, most people that have this other condition complain that it's not and say that, oh, it's just, I probably just ate a little bit too fast, or say it's heartburn. What's that other condition that they could possibly have? And more often than not, they do have it. They do have this other condition, but they think it's heartburn. Or they think it's acid reflux, but it's something else.
Angina.
Pardon?